Are certain types of inhalers better for the environment than others? What does a randomized clinical trial aimed at improving Avalanche survival look like? How common is new-onset postoperative atrial fibrillation after CABG? This and much more on today's JAMA Editor's Summary. Hello, and welcome to our listeners around the world. Today is Friday, October 10th, 2025. I'm Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network. I'm joined today by JAMA Deputy Editor, Dr. Preeti Malani. Hello, Preeti. We have plenty of interesting research to share today. Let's get started.
Hi, Kirsten. JAMA published 2 research articles on greenhouse gas emissions and inhalers. These articles appear in the Climate Change and Health section in JAMA. Inhalers, including metered dose, dry powder, and soft mist inhalers, are commonly used treatments for asthma and chronic obstructive pulmonary disease. However, currently marketed metered dose inhalers rely on hydrofluorocarbon propellants, which are potent greenhouse gases. In their serial cross-sectional analysis, Dr. Feldman and colleagues investigated inhaler-related emissions in the U.S. from 2014 to 2024. They looked at dispensing data from the U.S. outpatient pharmaceutical market to measure product utilization, as well as greenhouse gas emissions and the social costs of these emissions. The authors reported that a total of 1.6 billion inhalers were dispensed in the U.S. from 2014 to 2024, which generated just under 25 million metric tons of carbon dioxide equivalent emissions in the U.S., and metered dose inhalers accounted for 98% of these emissions.
In a second research report, Dr. Wepner and colleagues also analyzed inhaler-related greenhouse gas emissions. They used data from the Veterans Health Administration, or VA, from 2008 to 2023. The investigators reported an overall decrease in VA inhaler-related greenhouse gas emissions in 2023 compared to 2008. And they note that this was due to global policy and VA formulary changes from budesonide formoterol metered dose inhalers to fluticasone salmeterol dry powder inhalers. Dr. Rabin and colleagues wrote an editorial commenting on both of these research articles that helps to contextualize inhaler use and the production of greenhouse gases. The authors note that inhalers may be among the most promising opportunities for health sector decarbonization. However, they emphasize that treatment changes considered for environmental reasons should be grounded in clinical evidence, responsive to patient needs, and implemented with care.
Shifting gears, JAMA published a trial that may appeal to emergency medicine, critical care, and wilderness medicine experts alike. Avalanches in snow-covered mountain regions can be associated with a fatality rate of about 50% if the individual's head and chest are covered with snow. Dr. Eisendel and colleagues investigated a novel device that can enhance airflow to a buried individual's airways to delay asphyxiation without using supplemental oxygen. In this randomized clinical trial, 24 participants underwent a monitored snow burial simulation where they were covered by at least 50 centimeters of snow with either the SafeBack SBX device or a sham device. The primary outcome was time to an oxygen saturation less than 80% during 35 minutes of monitoring. The authors concluded that the SafeBack SBX device delayed hypoxemia and hypercapnia during the simulation.
Yeah, this is such an interesting trial, and we hardly see trials at such extreme conditions. And that's what's commented on by the editorialists, Dr. Martin and McKenna. They discuss more about avalanches and the risks faced by climbers and the teams that accompany them, and how important early intervention might be to improve overall survival in an avalanche. They also highlight how important well-done clinical trials like this can help us to learn more about human survival in extreme environments.
Next up, JAMA published a study about new-onset atrial fibrillation after coronary artery bypass grafting, or CABG. The incidence and burden of new-onset AFib after CABG are not known. However, 60 days, about 2 months, of oral anticoagulation is deemed reasonable by guidelines for patients with new-onset AFib after CABG. Dr. Herman and colleagues designed a prospective, multicenter cohort study to investigate new-onset AFib within the first year after CABG. They used insertable cardiac monitors implanted during the CABG surgery to continuously monitor for AFib for 1 year following surgery. The investigators found that the incidence of new-onset AFib among these patients was higher than previously thought. However, the burden of disease, especially after 30 days, was very low.
JAMA Associate Editor and cardiologist Dr. Greg Marcus wrote an editorial to comment on this trial. He writes that the primary lesson from this study is that postoperative AFib after cardiac surgery can indeed be reversible. Preeti, let's move on to talk about the research letter about minimum case volumes in surgical practice.
Sure, Kirsten. Dr. Karthik and colleagues investigated the relevance of minimal case volume recommendations for complex surgery. Minimum case volumes have been instituted by multiple organizations with the understanding that higher case volumes may lead to better postoperative mortality. Using the National Cancer Database, authors identified patients undergoing surgery for different cancers and the hospital's annual case volume thresholds and 30-day mortality rate. They found that from 2005 to 2019, fewer cases were needed to meet benchmark 30-day mortality. Specifically, the authors noted that although high-volume hospitals continue to show improved outcomes, the differences between hospitals above and below the minimum case volume recommendation have diminished. They conclude that current minimum case volume standards for complex surgical procedures based on older volume outcome studies do not align with contemporary practice.
There's another research letter that examines emergency Medicaid. Emergency Medicaid is a federally mandated but limited form of Medicaid that covers care delivered to stabilize individuals with serious medical conditions. These individuals would qualify because they would otherwise be eligible for Medicaid were it not for a number of factors, including their immigration status. In this cross-sectional analysis, Dr. Santos and colleagues evaluated trends in emergency Medicaid spending using data from the 2022 Medicaid budget and expenditure system. The authors reported that emergency Medicaid made up only 0.4% of total Medicaid expenditures. And although there were variations by state, this totaled an average of $9.63 per resident.
JAMA published a couple great viewpoints this week. Dr. Chong writes about primordial care, describing it as a space between primary care and public health. Read our article to find out more about this emerging pre-health space. And Dr. Kether explains the importance of understanding and acknowledging temporal medicine, especially for patients living with chronic disease. He explains how this framework acknowledges temporal care by encouraging clinicians to consider when an intervention is most effective and how to alleviate stress for patients that comes with uncertainty between flare-ups of chronic illness.
Looping back to chilly weather conditions, JAMA published an insight on extracorporeal life support in accidental hypothermia. Dr. Mendrala and colleagues define accidental hypothermia and review the management of hypothermic cardiac arrest and include helpful prognostic tools. And don't forget to tune in to the JAMA Plus AI Conversations podcast to celebrate the 1-year anniversary of JAMA Plus AI. Dr. Roy Perlis and Dr. Yulin Chuen reveal their favorite AI-related publications from across the JAMA network for 2025. And they'll also talk about what to expect in 2026 in AI and healthcare.
I do worry about more of this kind of cognitive complacency, more on a societal level, that we're using AI to think for us, right? And the same kind of fears that we have where the AI model is only as good as the data that we inputted, and we have to make sure the data is really good, it's very diverse, and it's updated. That's the other thing. It has to constantly be updated, similarly in, how in medicine where, we're using potentially practices that were based on studies that were 20, 30 years ago, right? That needs to be updated with new patient information, new patient demographics. And so I do worry that we will, both in terms of the AI drift, as I mentioned, but also this idea that because we're going to find AI so easy to use, right? Like Sam Altman said, is that, nobody born in the next generation is going to be smarter than AI, right? And that's because AI is going to do the work for them. So then where does the kind of human intuition and the creativity and the innovation come from? Because, in using these tools, you definitely know that they cannot create new knowledge, right? They can synthesize, but a lot of the time they're regurgitating a lot of information. And so if we lose that ability to think for ourselves, then we lose our ability to innovate and push things forward.
Cognitive complacency. I like it. I mean, I don't like it, but I absolutely see what you're worried about.
And a quick reminder that the latest articles in clinical medicine, biomedical research, public health, and health policy, written and researched by our outstanding JAMA Medical News team, are at jamamedicalnews.com, or you can click on the link in this episode's show notes.
Thanks, Preeti. And thank you for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Kirsten Bibbins-Domingo. This episode was produced by Daniel Morrow, Shelley Steffens, and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in the episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.